we're back with our final interview of the day. Thanks so much for sticking with us. We're pleased to welcome John Santopietro to the studio. Dr. Santopietro works for Carolinas Healthcare. Thank you so much for your time today.
It's great to be here.
Well, you take a team approach to behavioral health care, and you use it via a telehealth strategy. Can you explain a little bit more how that works?
Yeah, sure. So when I got to Carolinas healthcare system 4 years ago, one of the challenges to me in leading the service line of behavioral health was we have 200 primary care offices that serve 800,000 people. And the system knew that it wanted to get behavioral health into those practices. And the model that's been proven in the country to do that is a co-located model. So we would have had to hire maybe 600 people to be able to do that. Even though there was great energy for behavioral health, there wasn't that kind of energy. So, and it was just too cumbersome. So we got a team together that innovated and designed basically what we call a virtual behavioral health team. So that's now 25 people that are in their own office, basically, a kind of a bunker, and they're deployed to 70 practices, all over virtual technology. So the phone counts as virtual technology, but also telepsychiatry and therapy that they do into the primary care office. So it's really quite, in some ways it's not rocket science. It's using the model that was existing for integrating into primary care, but then innovating a little bit and using technology to bring it to people where they need it.
Okay, and so it's not just one person who's addressing a patient's needs, but an entire team.
Exactly.
And who's on that team?
Exactly, and importantly, there's only one psychiatrist, and there's one nurse practitioner. There's a person that does pharmacy, so a pharmacist that specializes in mental health medications. And then there's a number of coaches and a number of therapists. So if you think about, and the panel that I was on was about workforce shortages in mental health, particularly in psychiatry, where more than 50% of the psychiatrists are over 55 actually in the country. So in this model, we have been able to leverage the skills of one excellent psychiatrist through a team of 25 clinicians to 8,000 patients in 2 years. And it takes a particular kind of psychiatrist to have the energy and the outlook to be able to manage that and work through a team. He has great skills at being able to work through a team. But that's essentially taken one psychiatrist and delivered care through primary care to 8,000 patients in 2 years.
How do you know that this works?
Well, it's good timing for that question because we've just gotten our first 6-month cut of data, and certainly the stories were all good. The primary care docs were telling us that it made them more efficient and they were noticing their patients were doing better, and the stories that we got from the patients themselves, because it's not just about medications. The coaches, for instance, will do a callback protocol. They'll call the patients at home for 14 weeks, actually. So patients were telling us, gee, I didn't know anybody cared that much about me and my depression, let's say. But anyway, our first 6-month cut of data show us that suggests that depression scores have fallen by 50%. Anxiety scores have fallen by 45%, which is what we would expect if we're doing it well. But more importantly, relative to this conference in all of healthcare, hemoglobin A1C, which is a marker for diabetes, has fallen by a full point, which is with no other intervention other than integrating behavioral health into primary care. Total cholesterol has fallen. LDL cholesterol has fallen in this group, and those are all statistically significant. It also looks like, we don't have significance yet, but the trend is that ambulatory visits, so outpatient visits, are up a bit in this population, but inpatient visits look like they're coming down, and emergency room visits look like they're coming down. So if you treat somebody's mental health issue, well, they're doing better taking their diabetes medications, they're not needing to go into the emergency room, they're leading healthier lives.
Right. Now, how do you know when someone should be seen face-to-face?
Yeah, great question. Right now, 1/3 of our referrals come from the primary care team. So that could be the the primary care provider, it could be a nurse in the office, but 2/3 of the referrals actually come through screening. So if you think about population health, and if we really take on population health, there's a lot more emphasis on screening the population. So they do a depression screening, for instance, in primary care now called the PHQ-9. And anybody with a score at a certain level, we automatically get notified through our EMR, it comes to the team, and they are automatically on our registry. So at any given time, we have about 2,000 patients that team is managing or helping the primary care team to manage, but most of the referrals come through screening.
Okay. You mentioned earlier that there is a shortage of psychiatrists.
Yeah.
So how concerning is that, and what will it take to turn that around?
Yeah, well, I think both things are true. It is true that there is a shortage of psychiatrists, and we need to excite people that are in medical school about psychiatry, which I'm very much involved in with some colleagues nationally, because it's such an exciting field, really. We actually are starting a psychiatric residency program at Carolinas Healthcare System. Our first class is coming in July. But I would add the second point, which is it's not just more psychiatrists, it's what kind of psychiatrists do we need? You know, I think I mentioned the doctor that's in charge of this 25-person team and has leveraged his skill through a team to treat 8,000 patients. I don't know that every psychiatrist needs to be that ambitious, but what we hope to do in our residency program is, in addition to giving people the basic skills that they need to be excellent psychiatrists, we want them trained in leadership. We want them trained in system-based care. We want them to be very competent in working in multidisciplinary teams, because frankly, that's where the value of psychiatry, I think, is in the future. Not just a doc seeing patients in an office all day and then going home. It's a psychiatrist being a clinical leader, a facilitator of a team, you know, being responsible for more of a population of patients.
Okay. How has this conference been for you this time?
You know, it's been great. I was just commenting with somebody that in addition to the excellent speakers and excellent dialogue, something particular about this conference for me this year was bumping into people, some I knew, some I should have known but didn't know. So somebody that's a healthcare economist that was in college with me that I'd never known. And then meeting a lot of new people that are interested in, and I would say passionate about, the same things that I am. So that was particularly, I think, excellent in this conference.
Excellent. Thank you so much, Doctor. We appreciate your time today.
Thanks for having me.
And thank you for staying with us and tuning in and listening to our terrific interviews. Tomorrow we start bright and early at 9 o'clock in the morning with Robert Andrews, CEO of Health Transformation Alliance. I'm Mabel Zhang. See you tomorrow.